some financial evaluations right now to determine the financial impact, and then we'll be able to discuss this further. So I can say with almost 99% guarantee that it's not going to be added in 2026. But definitely any insights that you have during the rule, the RAC, please feel free to share them. If not for this year, but at least they'll be considered for the upcoming year.
Thank you. Appreciate the update.
So that's another case where I think HERC went along with the recommendation of this group, but then there are budgetary discussions going on and realities are colliding there. So thank you for that update.
Great.
And I did start recording midway through that, and I was taking notes earlier. So thanks, Liz, for the reminder to record. Oh, I should let you all know, for those of you who interact with us by email, Jessica Malmstrom, who was our administrative person for the last couple of years, has moved on to another role. So if you need something from HERC staff, please email herc.info@oha.oregon.gov, and that way we'll all get it, and one of us will respond as we're able, and I'll put that in the chat if you're used to contacting Jessica.
Great. Anything else before we jump into our agenda? Alrighty. So the first item on our agenda is the new CDT codes. There's a document in your meeting materials where, oh, thank you, Liz. This is the internal staff recommendations just for discussion. So I thought we'd just start at the top. The first one is, it looks like it's a collapsing of two current codes, the collection and preparation of saliva sample and then analysis of the saliva sample. Both of those are not covered. And so the recommendation is to continue to exclude. Does anyone have any questions, concerns, input? And then the next code
is so sorry, Ariel. Also, just for folks, usually you'll see one placement. This is the next immediate list.
Yes, thank you, Liz.
Go ahead. Thank you.
Yeah, so there's two placements now. Liz is kind of highlighting them. The usual one, which is for the January 1st prioritized list. And then because we are moving into the new benefit updates project world, there will be more or less the same recommendation for many of these. So things that are excluded will stay excluded, diagnostic will stay diagnostic. The third one there you can see is recommended for a line. That line will become a code group, but essentially be the same thing. But you'll see later on there are some differences in how we are going to be placing things later. So just as an FYI for you all, and if you had, and we can kind of explain those as we get to them. But if you are used to just seeing one placement recommendation, the reason we have two is because of the whole BUP conversion. Menu, I see your hand up.
Yeah, so I did some background research on this particular CDT code, and I agree with the assessment that it is currently unproven and doesn't have, and not within the standard of practice. However, I feel as though that immediately kind of committing it for January 2027, when potential more data and information could come out in a potential OHAP HERC review that could take place next year. I think kind of committing that right now for 27 to be excluded, I think is a little bit kind of putting the nail in the coffin, so to speak, or too early.
Essentially, this is the same thing we've always done. So if we were not changing to the BUP world, this would stay excluded until we act. So the 2026 placement would just continue forward with no change. It would be excluded until we act. So it's the same thing. We're just changing the names of some of our files. So it's really the same that you've always done. It's just some of the names and terminology will be changing. anything is fair game to be brought back to be rediscussed as practice changes, technology changes, evidence evolves. So if this is something that you feel next year that we should discuss, please send it to that herc.info and just say, hey, I want to put this on the agenda, or bring it up at the meeting.
Okay, thank you.
I mean, based on that discussion, I'm wondering if we should be designating it as not medically necessary rather than excluded, if it's really about lack of evidence rather than some sort of budgetary limitation. Has that been discussed?
I don't think the nuances, right, have been kind of brought to OHAB, but basically, functionally, if it's not covered, gets dumped in
Well,
excluded, right?
functionally, but there are implications like for
Right.
appeals and
But starting 27, there is a nuance of things that are excluded, like IVF, totally outside of the benefit package, versus codes that could theoretically be covered, but for their unproven non-standard of care nature or something like that. So
we can
would you
put
like me to make a change?
we can put a pin in that for today. But if anybody has immediate thoughts, it would be good to get those on the table here. So if it's excluded, it would be, just like we have services now like eyeglasses and a lot of adult crowns and root canals that are, HERC would recommend as good services, and would be dentally necessary, but are not in the benefit package. Those kinds of things would be excluded versus something that doesn't have a clinical benefit. We would, going forward in 2027, the typical place for things like that would be the not medically necessary file. That will be a new file that doesn't even exist yet, but will. So if anyone has thoughts on which of those two designations make sense for that, that would be helpful for us. I'm sure we'll be discussing that with Dr. Farag and our rules folks as well.
Does anyone have thoughts on whether so excluded means never, not appealable, not ever a benefit. Not medically necessary means sort of excluded light. It's not covered, but you do have appeal rights and you do have, exceptions and that kind of thing. I just made a note in my personal, my document notes to consider not medically necessary. And we can talk internally too.
Mm-hmm.
And everything for all of the BUP decisions need to be made, but a lot of the fine points may be evolving over the next year.
Right. And this is an example of one of those.
All right. Are we ready to move on to testing Gary, I see your hand up.
Yeah, thanks.
Go ahead,
just another comment on this. I think the implication would be on the EPSDT population. If it's excluded, then I'm assuming it'll be excluded for across the board. But otherwise, we would have to do a medically necessary review for EPSDT and justify non-coverage. So I think it's an important point. So I think it does warrant further discussion.
So this might be one for us to take back, but my understanding is that the boundary for EPSDT is what the feds would match, would provide federal match for, which is probably just about anything provided by a dentist. But there may be more nuance to that. So Ahmed, maybe we should follow up on that with the EPSDT team to get clarity about that.
I agree. Thank you.
I see no longer.
It's Karen.
Oh, hi.
Hi. I think I've said this before. When we say it's not medically necessary, but we're saying it's not covered, I think that can become very confusing to both members and providers, because a lot of times there's lots of differing opinions on whether something was medically necessary. So I guess I have that comment about putting it there. It kind of gets very complicated, I think, when we do that. And I thought even if it's excluded, if it's for an EPSDT member, if it was medically necessary, we still pay those. I could be wrong, mistaken, but that was my interpretation.
Yeah,
My understanding, and Jason can correct me, is that it's outside. So like IVF would never be medically necessary for the EPSDT population, or I don't know, some
Yeah, I think for dental, we need to get a little more clarity and maybe some talking points around this because it seems like it's a little bit just because it's an optional benefit, because I think there are some federal things at play. Let's Ahmed, let's get some talking points together about this. I mean, we've got a little time, but um,
So what I'm hearing is nobody is objecting to the 2026 excluded. Nobody's objecting to more or less not covering for 2027 and letting staff work on how that's going to appear. Does that sound reasonable to all?
Does to Karen.
Okay. Yeah. The really important thing for this meeting, obviously, is the 2026 placement because we've got to get that done. Okay. So the next one is testing for a cracked tooth. There are some basic office things like transillumination and bite stick that would be covered, but not cone beam CT. Internally, the discussion was that we want this for reporting and documentation, but it shouldn't be billed separately. So it would be diagnostic, but there would be a rule saying it can't be billed separately. Any objections to that? Okay. Influenza vaccine, please give influenza vaccines while we still can. So just as a reminder, there are two places that vaccines are going now. Line 3, just for clarity, for people to, if they want to look there, but they're actually being treated as exempt, meaning we don't care what you're being seen for, or you don't have to be seen for something on line 3. You could get your vaccine if you're at the dentist with a need for a root canal or something like that. And then the next two, this might be something where it is more in the excluded group, and it is duplication of complete dentures, because OAR excludes dentures to once every 10 years and specifically says that we can't duplicate dentures. Thoughts on that? Okay, I see a thumbs up. The next one, actually, there's a whole series of codes that are for maxillary and mandibular prostheses. These are we consulted with a maxillofacial prosthodontist, Dr. Larry Over. He recommends coverage. They're used for cancer patients. And so the recommendation would be to put these on lines that would have oral cancer. So that would be cancer of bones, cancer of the oral cavity, benign conditions of bone for non-malignant things that would be in the jaw. And then there would be a non-covered line for 2026, which would be the benign neoplasms that aren't really causing you problems. And then for 2027, it would just be the 3 covered lines. And then what we're doing is the 2 benign neoplasms lines of bone are being collapsed with a guideline saying, instead of having 2 lines and saying one's above and one's below, it'll just be what's medically necessary and what's not. Stacy?
Yeah, I was a little confused about this when we had our preliminary meeting, and this is a very small population of patients where a surgical reconstruction cannot be completed at the time of cancer resection. So these prostheses help prevent the jaw from swinging, and it really helps with preventing aspiration and chewing function. So I just wanted to clarify what these are used for.
So these are, I think there's 10 or 15 of these different flavors. Does anyone have questions or concerns about everything up to D5949?
I think I have a process-based question. And so,
Mhm.
Dr. Geisler, thank you for providing input about this. When I was studying and reviewing this, I didn't know. And I think off the back, because this is a very medically driven um, reality for these particular patients, why wouldn't this just be covered in under medical?
Because these are dental codes. There's presumably, yeah, there is. So there is a CPT code, which is on line 199. So that would be medical. And whether or not the payment for this CDT code would come out of medical or dental is beyond my pay grade. I don't know if Manu or Ahmed, do you
And
have any input there or anyone else from the dental?
yeah, sorry. These are covered under medical, but by virtue of being on medical lines and not the dental lines.
Well, no, but this is about how the CCOs allocate the cap rates to dental contractors versus their
Yes.
medical load. And I don't think that's an OHA decision. So am I correct about that, Ahmed? Since we have integrated
Yeah,
dental now.
yeah. Thank you, Jason. Yes, you are right. We really don't go into the relationship between how the CCOs uh, give money to the dental subcontractors, but in the same time, we at times say that these should be billed under medical, should be billed under dental. So sometimes we can do this in the rule by what is being considered under medical and under dental. But here, for whether it's a small population or a large population, if the provider really goes through and bills the dental, they should be covered. So allow us to look back in the rule and see where we could have some leeway around. To Ariel point, I think this is a further discussion with our WAFA team as well on how to allocate some of these funds to which area.
While thank you all for your input, and while Dr. Geisler has even pointed out that this is going to be a very small population, but this is going to be a very high cost. As president of Capital Dental Care, I know for a fact that we've never contracted with or I can't say never, but at least within the last 5 years, we have not contracted with a maxillofacial prosthodontist. And that, while I realize that operationally I contract with the CCOs, I think this would behoove us to have a more in-depth discussion of how do we truly operationalize this for the needs of the members who now this is being assigned to, particularly through a CDT code for treatment.
Yeah, and Dr. Chaudhry, I just want to add as well that some of the medical codes are unfortunately, not fully comprehensive to some of these dental codes. So they don't have exact parallel in the medical. Some of them do, some are not. So that's also another challenge. But we'll take that suggestion back and we'll investigate it further.
Right. And I realize that this is not an OFA discussion, but I do want to raise that the cost of exposed bond, as indicated in our rate setting, is anywhere between 5 to 7 times less than the true cost of care. And so I just want us to be mindful of, for the record, that we need to be careful of adding things in when truly providing this in the right way to ensure that the patient has a functional appliance at the end of the day is quite costly. Thank you.
Karen?
Yeah, I just want to make sure I'm understanding from the administrative side. So right now, by putting it on those lines, if we have a member that has these conditions, dental would need to pay it at this point, if no rules are written prior to this being implemented.
Well, so HERC would need to add this to the prioritized list, and then the program, the dental program and Medicaid will need to implement this. one way or another. So I think that question is what needs to be worked out. And I totally get that it's an important question. It's just not one that HERC has influence on. And so we're going to have to follow up on that.
Okay.
And
Yeah.
I've been
I
making
guess my
some
question
notes.
is by putting it on those lines right now, come 1/1/26, we would need to cover that if it came up.
We're asking, I can't answer that question. I don't know, Ahmed, if you're able to answer it or not.
The short answer would be yes. There
Okay.
is yes, and will be explained more as we dive deeper with our WAFA team and how they should allocate some resources for that. But the short answer is yes.
Got it. Okay. And the reason I ask those questions is because we have to start with our IT department on programming these new codes. And so it becomes very important to figure out what do we tell them to do at this point to get ready for 26.
Okay.
So what would be the other option? I guess not covering these, but that doesn't seem like the right thing to do for our population. So, Stacy?
I think I don't know if this would be helpful at all, and maybe it wouldn't be, but with other types of cancers in other parts of the body where there is a resection and prostheses need to be made, or there's kind of an interim prostheses that's made prior to final reconstruction, that might be perhaps useful to look at that and how those codes are handled. Because this is really, it's just happening within the mouth and involving teeth, but it really is a medically driven process. And these codes really are to reflect when the surgeon is not able to do a free flap. This is a very small group of people. These are not commonly done, was what Dr. Over told me. So I don't know if that would be helpful, but thinking it in that kind of framework, might provide some clarity.
So it sounds like internally the dental program has some work to do to figure out where all the stuff that HERC doesn't do, just figure out which bucket this comes from and which rules to write and all of that. Any other comments? Okay. I guess now we're down to D6280. The next couple are implant-related procedures, which are currently on line 612. And with the new BUP world, these will all be excluded, meaning they're not appealable to do implants. Now, going back to the question that was raised very early about like an EPSDT patient, if an implant would be really helpful for some reason, we'll have to figure out if, if these are, where these are, but right now they are outside of our benefit package. We do not do implants. Menu?
Prior, right above the D6280 line or row 21, there's some discussion, or not discussion, but some of these codes reflect prosthesis that are supported by implants. And so while we've
Is that what a fixed prosthesis is? Is that an implant? Sorry for my dental ignorance.
That's okay. I think Dr. Geisler would be far better and more informed. Dr. Geisler, do you mind?
No, I think I still have my audio on. Can everyone hear me okay? So
Yeah.
fixed prostheses, Ariel, really reply to or are related to reconstructing teeth or missing bone and jaw using either existing teeth, or in the case of a cancer patient, it might include placing implants because the patient anatomically, the anatomy is so abnormal that they could never wear a traditional denture. So an implant is placed, or a couple of implants, to help anchor that maxillofacial prosthesis. Fixed prostheses can also include like bridges. So you have a tooth pulled and the dentist cuts down the teeth on either side, and then 3 teeth are glued and cemented permanently. So fixed refers to not being able to really remove the prosthesis, and it stays in place, much like our natural teeth, versus removable, where you're taking things in and out.
And so I think the question is, if we don't cover implants and they're outside of the benefit package, is that also true for these implant-related prostheses? And again, this sounds like a question for us to work out with the program team and the actuaries. And so there may be a need for a different placement for those. And it looks like Manu is agreeing with that. Ahmed, anything you'd add?
No, I agree with as well. It's not always just dental implants. So those could be occipital implants, could be zygomatic implants. There could be, weird types of implants, 3D printed type of implants, just so they can build the structure of their oral cavity or face at times. So that being said, while it's not necessarily only dental implants, it could ultimately evolve into something that restoring some of the missing teeth or the missing oral cavity structure. So let's bring this one also back and add it to the list of things that we will need to discuss as a program.
Yeah, that might be something we could handle in rule, like which type of fixed prostheses we would cover. I'm just throwing that out there. Ahmed would know more.
Well, I would think if it's determined that they're not part of the benefit package, we'd want to consider keeping them off the prioritized list. So hopefully we can get to that before the end of the year so that we can have that figured out before the November HERC meeting.
If I can just interject, what this all has in common are these are people who, because of systemic diseases, they have pretty severe deformities. So they could never wear any other kind of prosthesis. So this would be a small category of patients.
So I have the D5946 to D5949 as something to discuss internally, possibly exclude, possibly write a rule. Does that kind of reflect the conversation?
So I think it's all those codes we need to discuss, but we need to discuss the ones that contain the word implant in a different way.
Fixed prosthetic. They don't have implant.
Well, no, they also have implant. Some of them do. Like D6196 does. And
6196. Right, yeah, that one's already slated for excluded.
No, I think we're referencing those that are above row 20.
Yeah.
I'm sorry.
I was
6049 also says implant surfaces.
No, so it was D5946 to D5949. They don't have the.
Oh, no, they do have the word implant. It says implant/abutment supported. So it could be an implant or an abutment. So yeah, we'll need to think about these individually, I think. I think we lost Ariel maybe.
Please, my other colleagues to weigh in as well. But, to Jason's point earlier, 100% agree that if the procedure description has the word implant in it, it needs to be taken back and reviewed more appropriately. Because if we're covering the final restorative option for implants, then we're essentially covering, then we're having a different conversation with what's been covered by the benefit package.
Okay, so it's D5942 where it starts saying maxillary implant down to D5949.
Yes, that's correct.
Okay. So I've flagged all of those as needing further discussion.
And just since we have the technical experts here, what's an abutment? Is that typically a dental thing? And if so, is that in the benefit package or is that more of a medical?
Stacy?
Yeah, I think an easy way of thinking about that, or all of this, is excluding dental implants for patients who do not have cancer or severe pathology that require resection, loss of jawbone. So all of these are falling into this. The dentist to connect the prosthesis to the implant. And really the maxillofacial prosthodontist, they decide whether a fixed option or a removable option is appropriate. And there's ways that to control costs, you could limit, whether it's removable or fixed. Fixed tends to be the most expensive because it requires the most implants, has to do with mechanics and engineering, which we don't need to discuss here. But if you're concerned about cost, you could just limit this to removable prostheses for patients with severe deformities of the maxillofacial skeleton. So I think there's a way to exclude implants for routine kinds of procedures, but allow the possibility or review for these patients that really are terribly deformed. They can't eat properly. They have trouble with swallowing. They have lots of issues. So
I'm kind of hearing maybe anything with the implant, the D5942 going down might be better and not medically necessary. That would allow them to be reviewed, but not automatically paid. Does that sound like a reasonable option, Ahmed? Others? And Manu, I see your hand up, but I want to hear it with the group. Okay, I see I have fingers, thumb up from Stacy. Manu, did you have a comment?
Just from a cost-based perspective, well, actually, wait. So regarding medical necessity, I think I think Dr. Geisler really focused in on why these prostheses are needed, which is for something that is medically necessary. So I'm not sure if I can maybe in context in what has been presented agree that it shouldn't be or it should be considered non-medically necessary. And then the second rub, the rub that I have that I wanted to share is, I haven't practiced this kind of stuff for years, but when I had, we were looking at some costs of somewhere between $25,000 to $50,000 per arch to create. And so I just want us to be mindful of the costs and the burden that would be applied to the dental subcontractors and the dental providers that are providing that care, because these are very high ticket items, even though they're a relatively small population. Thank you.
Could I ask a clarifying question? This is Liz to Ariel. Would you like me to change this current Excel, or is this something, or would you like
I'm
it to
taking
stay?
notes, Liz. And I've changed it on my notes so we can, yeah.
I
And
think you should say staff to follow up on this one is what you should say for these. I think we need more discussion.
Okay.
Yeah. Jessica, and then Ahmed.
Hey, I just wanted to bring to everybody's attention too is that sometimes we have OHP members who have existing implants. And so this is not providing an implant. It's somebody who has possibly an existing implant and just using that as an implant. So I just wanted to put that reminder out there.
Oh, I see. So they have an implant and they're using that as the kind of base of the. Okay.
I mean,
Ahmed?
that could.
Yeah, I would agree with Jessica that some of them might get the implant during the surgery, and that could be a different story that could be built differently on their medical when they are putting the implant, and then the prosthesis will have to be fabricated afterwards. But thank you, Manu, and thank you, Dr. Geisler. I think just from the get-go, those are medically necessary. So we can't really say they are not medically necessary. So I agree with Manu on that. It's a great suggestion to keep our options open, but the reality is different. So they are medically necessary. how we will go about it, how we will adjust our programs, rules, guidelines, whatever we will have to do to make sure that the utilization aligns, is absolutely something that we need to work on. But those members, and as Dr. Chowdhury had the wonderful experience treating them, and I did the same, I know they don't have any other options. So having these is a lifeline for them.
So just to summarize, since I'm not a dentist or even a doctor in this context, there's two issues. Like, I don't hear anybody disagreeing that they're medically necessary. What I do hear is a question of, are they in the benefit package if they involve implants? I also hear, would a removable prosthesis be a less costly option? And there's also the angle of existing implants that pre-existed prior to the surgery and how those might affect any of that decision making.
Yeah, I think there's a concern, Jason. What I'm hearing is the controlling costs, because these are
Well, right. That's underlying. Who's going to pay for it? Yeah.
Right. And HERC, we don't make those decisions, but it really is standard of care. Some of these people do have to have implants, but you don't want to open it all up, to every single member because.
Right.
Yeah. And perhaps, rules could be written or setting this up for review and giving the CCO some leeway so that they can have some assurances, that less expensive options might be pursued. So a removable implant retained prosthesis versus a fixed.
Okay, that's super helpful. That gets the issues on the table for us to have those internal discussions, and I'm sure that will be discussed in a rulemaking or in some other forum.
Okay. Great. Thank you so much for your input. Any other? So I think we've made a lot of notes, and you can see on the screen that there's going to be no recommendation out of this group. So Jason, I'm assuming that we can talk internally and then maybe send something.
Well, this is a staff advisory panel, so you've just got a lot of information, and we can revise and create a recommendation and send that to HERC when we're ready. And those who are on this call who may want to offer public comment on that recommendation when it comes are welcome to do that. And then if there's rulemaking, of course, there is public comment opportunity and a RAC to participate in as a part of that process. I believe there's also that other oral health meeting that happens that I think many of you are engaged with. So there will be other opportunities to provide input on this issue, and we will all be talking to each other within OHA, coordinating as best we can.
Okay. So now we'll go back down to D6280, D6049, D6196. They're all implant maintenance and removal. They're slated for excluded. Does anyone have any concerns about that?
Are any of these fall into that category where somebody has a self-pay or pre-existing implant? And would that change whether OHP wanted to cover it? These are maintenance, it looks like, not installation.
I think with the previous discussion that we'd had on the D6101, which is on line 612, is that once you start doing maintenance procedures, you kind of own this, and that there was some concern about that.
So are these the same? Is that, or these look like cleaning. That might be different than, I think the other one we talked about was replacing a screw or something.
It's kind of to Ariel's point that was raised. Yes, that's my recollection as well. When we do any type of implant maintenance procedures, we have to physically remove the prosthesis from the mouth and then clean it both externally and then also intraorally as well, and then put it back on. And during that process, screws could be broken. The rubber gaskets that's used as well could be torn or broken as well. And once, at least most dental folk, once we touch it, we own it, and that's just how it goes.
Mhm.
You break it, you fix it, I guess. Sorry, little dental humor for the morning.
So I'm not hearing anyone object to line 612 and then excluded file, again, knowing that there may be some internal discussions about excluded, not medically necessary, all of that EPSDT kind of discussion for 2027.
This is Tom Holt in Coos Bay. I think it's important to acknowledge that making the decision that implants are now at least sometimes medically necessary changes the entire scope of how implants are approached for plan members. And so all of the implant related codes, I think, need to be, I think it was like, was it Jason on there who said, people who aren't dentists need to get educated up into what implants are, because there's probably not a lot of understanding of implants because they haven't been covered as a whole class of services. So I think that a lot of this will be a lot more, if it was medically necessary, if they have a prosthesis, then maintaining that is medically necessary, whether or not them getting a new one would have been. Like how we define medically necessary in an implantable prosthesis is it's easy to understand once you've accepted the fact that and not touching it doesn't mean you don't own it, right? So if your patient has it and you have that patient, you kind of own it. So I think the idea that if you touch it, you own it is a little old-fashioned mentality of dentistry, where we can think that we don't have to do early periodic screening, diagnosis, and treatment. So I would just invite a more deep dive into the overall world of implants from staff, and then not have. I think it'll be simpler than trying to micromanage all these codes. But this idea that implants are medically necessary, that's a huge thing for Dr. Farag to have said, right? So that's a big shift for the Oregon Health Plan and for our members, and it's gonna have a lot of cost implications and rule making.
So let me just adjust. So I need to distinguish a couple concepts here. So there's medically necessary, which is it safe? Is it effective? Is it the best treatment for the patient? Is it the least costly option? That's one question. And eyeglasses, I'll just give a simple example. I've got them on my face here. You can all see them, medically necessary. However, they are not part of the OHP benefit package. And so nothing I said was intended to imply that putting in a new tooth implant should become part of the OHP benefit package. That would be a budgetary decision that HERC can't make, and would require money from the legislature or the agency budget. And so medically necessary, and then there's the EPSDT dimension that we talked about earlier, and I think it was before you came on, Tom, that we need to get some talking points around what the rules are for things that are outside the dental benefit package. We had this happen with handicapping malocclusion a couple of years ago. It seems like this is coming up now. So kind of parking lot those issues, those aren't really HERC's discussion today. HERC is kind of focusing here on the clinical, is it medically necessary? But we're trying to reflect the benefit package to reduce some of that conclusion. So this discussion is all helpful for that. So when I said it's medically necessary, please do not interpret it as that's on the table to be covered now, because we're not there. But the question about if it's already there, should we clean it? Like I asked that, Dr. Chaudhry answered. We'll have further internal discussions, and I will try to get some more clarity on that going forward. So I hope that helps.
I see Stacy and then Ahmed.
I just wanted to kind of piggyback off of what Tom said. So from an economic standpoint, if implants are being placed for this small group of patients that have severe facial deformities due to cancer, or other types of aggressive pathology that requires a lot of surgery. They're missing half of their jaw. It would be prudent to allow for cleaning and maintenance of the implant as well as the prosthesis, right? So if it was paid for, it'd be kind of, I don't know if the word is foolish, but to not take care of it and examine it and clean it and all those kinds of things that are required for good oral health. It would make sense to me to allow those services. And then also just people who have had implants and prior to coming onto OHP, it's hard to say, well, we're not going to cover any of the cleanings and so forth and the maintenance of the implant, especially if they start having bone loss, if the implant fractures, if they're having pain. It would be difficult, I think, to justify just excluding that. I don't think that's acceptable patient care to allow them just to go on and have this infection with the implant. I know these are complex issues, but I do think that for the people with these severe deformities that implants can be medically indicated. I don't think every single person needs to have implants when they lose a tooth. We have other more cost-effective ways of replacing teeth.
Ahmed?
Yeah, thank you, Stacey. I was probably going to say half of what Stevie said, so thank you for making it easy for me. That's where we stand really. But I will just go back to what Stacey mentioned. We're really not necessarily here to discuss how financially these can be viable. These are discussions about, is it medically appropriate? Is it medically necessary? And then the next phase is to find out if it's financially feasible and how, and if we need to put some guardrails, rules, and regulations around what to be covered and what's not. So that's where I really want you to get on with your agenda and get over the codes. But I will comment on Tom's point. Tom, when I say implants are medical necessary, there's a foot implant, there's a hand implant, there like a chin implant, there is a chest implant, there a heart implant. Implant is implant. Doesn't mean necessarily I'm talking about dental implant. And the 3D printed prostheses that are fitted on the skulls to reconstruct a face are still considered implant. So when I say for those cases, implant is medically necessary, those are the implants I'm talking about. I'm not talking about dental implant to restore a single tooth or other, like Dr. Gessler's was mentioned. So just wanted to clarify that component, but thank you for your comments.
Okay, so staff have taken notes on this. Sounds like we have a little bit more internal discussion to do.
I guess I'm going to throw out there, implant maintenance is not maintaining the implant, it's maintaining the patient's body around the implant. So we're treating perimucositis and periimplantitis, which is inflammatory disease, which we all know is really important. And so not treating an implant that's pre-existing isn't treating the implant, it's treating the patient and a tiny little margin of where the patient meets the implant. So that's what we're treating when we're doing implant maintenance.
Okay, thank you. All right, moving on to sedation. Anesthesia codes currently for dentistry as well as for all the other medical surgeries are ancillary, meaning that they're covered if the underlying procedure is covered. So putting in a new implant, we wouldn't pay for the sedation, but doing a root canal, we would. So the recommendation is for D9244 all the way up to D9225. So going from like minimal single drug sedation to full general anesthesia would all be ancillary. Questions and obviously there's probably rules, other things that may have to go into place, but generally we want to do the appropriate sedation or anesthesia. Any discussion on those? Then the next two codes are photobiomodulation therapy. This is a form of low-level laser therapy. We currently have coverage on the medical side for photomodulation, or I'm sorry, for low-level laser therapy for prevention of oral mucositis for members undergoing cancer treatment. And so the proposal is to add it to all of those cancer lines. And then we have a guideline note 231 for low-level laser therapy that says it's included only for prevention of oral mucositis for members undergoing cancer treatment associated with increased risk of oral mucositis, including chemotherapy, radiotherapy, and/or hematopoietic stem cell transplant. And we would need to do a small edit to that guideline. It currently only has a HCPCS code. These two CDT codes would be added to that. Concerns, input on that one? Gary?
No, just a comment that I appreciate that, and if I'm interpreting it correctly, the guideline note does limit this to mucositis secondary to some sort of cancer therapy, because the group that recommended this CDT code be added was the Photobiomodulation Society, basically. And they described several usage opportunities to include post-surgical to reduce inflammation, and just the clarity that it would not be covered in those situations. I think it's helpful because once we approve the code, potentially we're going to have requests to cover it for more than cancer therapy. Oral apathy, for example, was another clinical use scenario that they suggested. TMJ was another clinical use that they suggested. So limiting it to cancer therapy, I appreciate that you've done that. I still think it potentially could present problems, but we'll go with the guideline note.
Just to be clear, Gary, the problem would be somebody seeking it for another indication besides cancer.
Correct, because that was the intent of the group that recommended this code be added. It was for far more than just oral mucositis secondary to cancer therapy. And the evidence, I'm sure, suggests that, yeah, there are indications beyond that, but the clarity that we would not cover it in those situations is very helpful.
Okay. Any other input there? Okay. And then the last code, D9936, it's cleaning and inspection of a occlusal guard. We don't pay for occlusal guards. And so recommendation is for the 2026 list would be line 639, and then going forward excluded with all the caveats that we've discussed already about what that means for excluded. Input, questions, thoughts? Okay. Well, thank you all for your input. Sounds like we as staff are going to have to do some talking. And this currently is slated to be discussed at our October 9th, our October 9th HERC meeting. If there's a lot of hangups internally about some of the placements, it may come to our November 13th meeting. So please keep an eye out for those agendas, and you are all welcome to come to any of those meetings, give oral testimony, just listen in to see what the final discussion is. And if there's nothing else about CDT codes, we can move on to Cone Beam CT. So this actually was discussed a year ago, and then kind of put on ice while we did all the benefit update project. So I'm sure you're all aware Cone Beam CT is a way of capturing images in a more 3D format, and it has some benefits compared to traditional dental x-rays. And some drawbacks. So, and there's traditional sort of facial CT scans. and they're used for non-dental indications, like looking at an oral pharyngeal malignancy, for example. So there's lots of different ways to image the oral cavity. So way back a year and a half ago, in February of 2024, you all asked us to do an evidence review on cone beam CT. Then we brought that back to you in May of 2024, and we found that cone beam CT was more effective than traditional dental x-rays for detection of tooth fractures, periodontal bone defects, and periapical bone lesions. It was more effective for detection of dental caries, but that's not standard of care. And it has been shown to change clinical decision-making in high difficulty cases, diagnosis of symptomatic teeth after failed root canals, evaluation of periapical healing, pre-surgical treatment planning, and management of traumatized immature teeth. So based on the discussion in May of 2024, there was support for adding additional coverage for cone beam CT. I should back up 1 second. Currently, we only cover it for handicapping malocclusion in people up to age 21. So there was some support for adding additional coverage, but there was a lot of discussion about which indications, and staff were directed to work with an expert and kind of bring back more information for you all. So there was a list of things that you all felt should be possibly considered: impacted teeth, complex third molars, supernumerary teeth, imaging of oral pathology, and orthodontic surgery. You did not think we should be looking at tooth fractures, periodontal bone defects, or periapical bone lesions, but you wanted additional information on initial root canals versus just root canals in molars or just retreatment of root canals. So, and staff were directed to work with an endodontist. I had some conversations with Dr. Adam Lloyd, who is a professor at OHSU in endodontics. He is quite in favor of cone beam CT and uses it daily. And he recommended using it for basically redoing root canals, molar root canals, etc. So essentially what we're trying to decide today, it does appear that cone beam CT is more effective than traditional dental x-rays in multiple types of oral conditions. And so we are recommending, for discussion, that we remove, well, first of all, we added a whole bunch of cone beam CT codes to the handicapping malocclusion line. And the recommendation is that we actually take those 4 codes and put them on the diagnostic procedures file, which is where most of our imaging is. And then there's a couple of cone beam CTs for TMJ. We would put them on the TMJ line, which is currently not covered. They'll probably end up being excluded in the BUP world. And then there's another series of 8 cone beam CDT codes that are currently excluded. We would also move those to diagnostic. And then we would we would change our endodontics guideline. It currently says advanced dental imaging is included only for surgical planning for craniofacial anomalies and handicapping malocclusion. We would strike that, and we would adopt a new diagnostic guideline for cone beam CT, and that it would limit cone beam CT. It can't be done as a substitute for traditional diagnostic dental x-ray for screening. And then it is dentally appropriate for planning in one of the following: complex third molar extractions, evaluation of impacted teeth, evaluation of supernumerary teeth, imaging of oral pathology, prior to orthodontic surgical procedures, retreatment of root canals, prior to root canals on molars, and required for surgical planning to repair craniofacial anomalies and handicapping malocclusion, which is, that last one is our current coverage. And I'm sure you all have thoughts on this. Gary?
Yeah, thanks, Ariel. I'll start it off. I am confused by well, first, I appreciate the evidence review and the addition of additional situations where cone beam would be medically necessary and dentally appropriate. Uh, I I am confused. Well, first off, and I know we're not supposed to talk about cost, but this is going to add considerable expense to the dental plans. And I think we may need a little bit more guidance on this. But your number one on the guideline note says it's not to be done for screening, and that seems to be contradictory to number two, B and C, where it suggests that it would be appropriate for evaluation of impacted teeth. And I wonder if rewording that to say for the purpose of surgical planning rather than just evaluation, because evaluation could be done with a panoramic radiograph, both for third molars and for supernumerary teeth, but where CBCT would be more useful would be in the surgical planning to remove those. So that would be my comment and concern about the confusion of when it would be utilized. Thank you.
Oh, I see. So we actually start out too by saying it's dentally appropriate for planning, but we then just say evaluation. So surgical planning or evaluation of impacted teeth for surgical planning, some wording like that.
That would be my recommendation because the evaluation part of it has essentially already been done by the panoramic radiograph. You have evaluated that they're impacted teeth and they need to come out. We already have, even though there have been limitations on coverage of CBCT, we had already allowed exceptions for cysts and tumor removals where localization was important, and occasionally for very deeply impacted third molars. So we've already allowed some of those exceptions, but again, it was for the purpose of the surgical planning aspect of it, not just as a routine evaluation type of application.
So actually when I'm looking at this, we might actually want to say CBCT is dentally appropriate for surgical planning for one of the following: complex third molars, and then just say impacted teeth and supernumerary teeth. So everything is for surgical planning for those.
That would be my recommendation. So it's not just taken as a matter of routine whenever somebody has impacted third molars.
And then we would take out, I think it says like prior to orthognathic surgical procedures. It would just say orthognathic surgical procedures, retreatment of root canals prior to root canals on molars. Yeah.
Ariel, does this all look good?
Yeah, that's kind of what no. So for B and C, it would take out evaluation of.
Got it. Thanks.
For G, would you take out prior to? For root canals and molars?
Probably, yeah.
Yeah,
just for parallel.
I think so.
And then also here, I guess.
Yeah, just be craniofacial anomalies and handicapping malocclusion. Those could even be separate.
Yeah, we could separate the craniofacial anomalies, and then handicapping malocclusion would become I.
Do you want repair of, or do you want them just by itself?
Hopefully you're repairing something.
Yeah, I would probably say craniofacial anomalies because we've said it's for surgical planning. You probably have already gotten like a medical CT for a lot of the craniofacial anomalies, but this might be for when you're doing the dental repair. I see Tom and then Stacy.
So some of the principles of ALARA, which are to minimize the only downside of a CBCT is the increased radiation. And there's cost, we're not talking about cost, the increased radiation. And the two ways that you reduce, the biggest ways you reduce radiation is that you don't do any radiograph for screening, they're for diagnosis. And you don't retake x-rays if you don't have to. And so when I got my cone beam machine and I figured, oh, I'll probably do some and I'll do some panos. Then the first time I did a pano and saw a molar that I knew it needed to work on and wished I could see it in 3D. Now, if you take a pano and then now for a diagnosis, we're not doing it for screening, and then you're going to take a cone beam for treatment planning. That's ridiculous. That's unnecessary. So, also taking off periapical lesions and periodontal bone loss, those are the two workhorses of where cone beam excels above. You can't diagnose anything on a 2D, any 2D image of a maxillary molar with three roots that are superimposed. And I'm chiming in here as, you know, I saw this coming up, which is why I'm taking time away from my actual patient care. I treat these patients all day, every day, members using cone beam. And it is critically important for diagnosing. Well, let's just say it's way better than periodontal disease. I don't know how important diagnosing periodontal disease is, but it's way better than 2D imaging. So taking it off the list is curious to me. And periapical bone lesions, that's the lion's share of what we're treating in emergency dentistry, and it's superior. And so the idea that we're only going to take a cone beam after a pano, once we know we're going to do surgery, you don't know you're going to do surgery until you have the complete diagnosis. You don't get the complete diagnosis until you have the better image. So the other kind of counterpart, which was going to be my first question until you teed up my second part, which is the wrongness from an ALAR perspective of how we're approaching this, is that we've got these like indications for CBCT, and I wanted to go back to what are the indications for a pano, because I'm not really aware of a specific set of procedures that approve or like make appropriate a pano. Because I can't actually imagine a single indication for a pano that a CBCT isn't way better, because a pano is actually a specific projection, right? And so that's why you can render it from a CBCT, but you don't actually have to render it from a CBCT. So I really don't like the idea of limiting all these things to surgical planning, because it's about the diagnosis. That's what radiographs are for. They're not for screening, and they're not for second level planning. They're for diagnosis.
Stacy?
Yeah, I just want to thank the staff. You guys have done a great job of reviewing the literature and putting this together. I think it's interesting. I get asked this all the time. You know, is a CBCT the standard of care for dealing with surgical aspects of the jaw? You know, wisdom teeth impacted, pathology, supernumeraries. And I would say that we can start with 2D imaging, but within that category, if you can see that there's issues, then you're going to go right to a CBCT in order to get a more accurate diagnostic picture that then enables the complete surgical planning. So for example, I had a patient yesterday. He actually works for the FBI. He's also an attorney. And he came in and he had 2D imaging, and it was a third molar consult. And there was some concern regarding that image, that 2D image. And we did a 3D, which allowed me then to make the diagnosis. And then we did the appropriate surgical planning. So I hear what Dr. Allen, and I agree with, I think these are great edits, but there is a place for using 3-dimensional imaging for diagnosis. And then the surgical planning flows from that. And then also I agreed with what Tom had to say. The radiation exposure is always a concern. My CBCT machine, it's lower radiation than periapical imaging, which is hard to believe, but it's a very expensive machine. So, and we are able to render 2D images off of that, but we just work with the 3D. So I don't know if this is making things more complicated. But I just wanted to thank you for the work. I think it looks really good. And then also the endodontic procedures are considered, you know, these are surgical procedures as well, right? Doing root canals. So I think just this distinction between whether we want to allow CBCT in certain circumstances to be used for screening, not across the board, but in select cases, we're going to go there anyway. And yeah, so that's all I had to say about that.
Gary?
Yes, thanks. Just to clarify the typical scenario when we're talking about third molars, certainly in our practices, and none of our advanced dental practices, have CBCT, and very few of our contracted PCDs have CBCT. So typically, they're either clinically diagnosing the presence of third molars that might need extraction based upon the clinical signs and symptoms, or they, in fact, many of them are still taking not even panos, but periapical radiographs to determine the impaction. And then they submit it for referral to an oral surgeon. So, and a lot of those don't even meet criteria under our guideline note for extraction of impacted third molars, because we don't routinely take out all third molars prophylactically. There has to be some level of clinical signs and symptoms or pathology. So, and then, if it's required for surgical planning, to address the point of ALARA, then, rather than a whole mouth CBCT, then they can do a focused, limited scope CBCT. So, because we would not approve a whole mouth if they're just taking out third molars. We would not approve a whole mouth if they were doing a molar root canal. It would be the limited field of view. So, I just want to make sure that there's some understanding of the typical flow for diagnosis and treatment planning. Thanks.
Okay. So it sounds like surgical planning people are in favor of. I think, Stacy, I heard you talking about like evaluation of impacted or supernumerary teeth, although I think Gary kind of responded, we would do a limited CBCT.
Yeah, and that's great, because the limited field of view addresses Tom's concerns because you're not exposing as much area to radiation. So that's like right on with that. But I would tell you that like supernumerary teeth, these are extra teeth that are stuck up in the jaws next to roots of other teeth. We have to do 3D imaging on that. We just, in terms of standard of care, I think if we had all the oral surgeons and probably periodontists in the state, they would probably agree with that statement. It's just, it's such a good, we can really localize the tooth that minimizes damage to adjacent teeth. And then the thing with the molar, again, I don't do root canals, but my understanding is just that they can really identify these canals and they can, from the get-go, provide really good treatment. So there really is an indication for using CBCT for the diagnosis and effective surgical treatment planning to minimize patient harms.
Okay.
And can I go back? I'm wondering, what are the indications where a pano is covered? Because I'm thinking that a pano should probably not be, I think panos are like really just covered and not questioned. And I'm kind of curious why CBCT is going through this whole evolution of like having to justify itself when panos are just accepted and they're a really compromised projection. It's not just a straight projection. It's a generated projection. And that also goes back to where we're talking about like CBCT can create images, 2D images, right? We're talking about a projection and exposure. This is the procedure is the exposure and the collection of data from it. So why can I use my same machine to do the same motion and capture 2 dimensions worth of, or it's actually just data. It's just data from a projection that shows a 2D image when I can have the same machine for the same radiation capture a 3-dimensional worth of data and show me the same image, but also more So if I need more treatment planning, it's already there. I don't have to re-expose the patient. This idea of re-exposing the patient when we go back and once we realize there's a problem, now we go back. Now we're using the first X-ray was actually screening. So the whole point of ALARA is you take the most likely to diagnose. Otherwise, it's screening. So a panel for screening, because I remember when I bought my Pano and we were worried about the exposure of a Pano. Pano to me is a dinosaur. There's no reason to ever take a Pano, considering that most of the people nowadays are going to be taking their Pano on a cone beam machine.
So the CDT code for Pano is diagnostic, and I don't believe we have any limitations on that right now.
Then I think that's what CBCT should be. The only reason you wouldn't do that is cost. And if that's not the question we're having here, then it should be just like Pano.
Gary?
Ariel, if I could comment, there are limitations on Pano and on full mouth radiographs. They're allowed once every 5 years, either or. And, again, to my point, very few of our offices have invested in CBCT. There's a considerable price tag associated with it. But if, we're finding, and, Dr. Geisler mentioned that, sometimes with the CBCT, you can just take a Pano. So depending on what the indications are, and this could be done in rule, that the rule could be modified to indicate that, either a full mouth radiograph or a Pano or a CBCT is allowed, once every 5 years. Perhaps that might address for those that only have CBCT, although again, they could take a Pano. So, that might be one way of addressing this for those offices that have invested in a Pano. Because I agree, it certainly does have superior diagnostic capability, and that's why a lot of providers have gone to CBCT. But whether or not we want to still allow it just across the board for initial diagnosis, I think that could potentially be problematic, but it could be added.
So what I'm hearing you saying, Gary, is instead of putting these in the diagnostic with a guideline, another possible approach would be making them diagnostic without a guideline, but having a rule limiting to once every 5 years.
Yeah, for offices that are utilizing it for their initial new patient examination, for example, that might be one consideration, as opposed to again just allowing it for because then you're at least limiting it in the rule, as we currently limit full mouth radiographs and Panos now.
But then if 3 years later the patient needs one of these surgeries, would they get another CBCT for the surgical planning? Is that what you're saying or not?
We have allowed that based upon medically necessary. When they were asymptomatic third molars and the Pano was, say, 3 years old, they took a periapical then to get an updated diagnosis and localization of the third molars, and then referred them out. And then, if it's a complex or it's an outdated Pano, then we have, by exception, maybe we're unique as a plan, but we have, by exception, allowed either an additional Pano or a focused CBCT for surgical planning based upon medical necessity.
So, Gary, I'm kind of hearing you saying that there's an alternative. We could limit the frequency and rule, allow exceptions for more frequent. So that's something that we can discuss internally. Stacy and then Asma.
Yeah, I just wanted to clarify too. I have patients coming in, they come in with 2D imaging. Like Dr. Allen was mentioning, some of these they don't need to in my opinion, I don't do CBCT on them. If I have the 2D image, I feel confident, I will go ahead and proceed to surgery. So, but there is a group of patients, like the gentleman I met yesterday, where he has a more complex case. The standard of care really is to perform the CBCT. supernumerary teeth. It really is the standard of care. The same thing, the endodontist would argue that it's becoming or has become standard of care for molar root canals. Orthognathic surgery, corrective jaw surgery, it's really the standard of care now. So just wanted to clarify.
So I'm just throwing this out into the world, kind of putting you and Gary's comments together. We could write a rule saying CBCT or Pano once every 5 years, additional CBCT within that 5-year span for surgical planning.
Correct. And in my opinion, with these criteria being met, or, there's the patient needs to have, they had a Pano a few years ago, and now they're getting ready to go through corrective jaw surgery for handicapping malocclusions, or they need a root canal on a molar, or they have a supernumerary has been identified.
Okay. And then Asma, did you still have a comment?
Hi, I'm Asma. I serve as a dental director for Multnomah. I did have a comment, but Dr. Franzen very well put that in the chat. I'm not disagreeing with the conversation around CBCT, just sharing that to not call CBCT or to eliminate Pano entirely would be extremely challenging.
Mm-hmm.
And thank you, Dr. Geisler, for making that point, which is why I put my hand down. You said it really well.
Alyssa?
Yeah, maybe I'll just build a little bit on what Asma is saying. For a lot of our patients, the cone beam is additional exposure and an additional procedure because typically what's happening, right, is a patient is seeing somebody with their primary dental provider who does not have a cone beam machine, but has identified something through either Pano or full mouth x-ray, other clinical indications that requires now them to go to the oral surgeon, the endodontist, or wherever they need to go. And if a cone beam becomes then necessary for that higher level of care, it's automatically going to be an additional exposure. And I think what Gary's talking about around sort of this group of things, once every 5 years plus this sort of situational, I think both would be needed. But I just want to make sure this group understands that everybody doesn't have a Pano, right? Like I understand that, doesn't have cone beam. So this sort of notion that it just should become the screening tool isn't the reality of where most of our providers are. And plans need some protection against then going to the oral surgeon, and some of them want a cone beam on every single person. So Stacy, I appreciate your comment. That's also not necessary. So we're in a place of we have the Pano, we might even have a Pano and periapical or other imaging, and the oral surgeon is wanting the full meal deal again. And if there's not enough criteria, things around surgical planning language, we're then in a place of all of that imaging becomes covered with not much parameter by which to control for that going forward.
So you're in favor of the guideline just possibly allowing it as a substitute for Pano for those people who have them, or?
Yeah, I think so. It'd be helpful to see it on a piece of paper, right, and be able to say yes, I think that's it. But I'm hearing the conversation for people that have the cone beam and not necessarily wanting to take a Pano. But we're not talking about the majority of offices that actually don't have that technology, and then the patient's need for a higher level of care requiring additional imaging. Or being requested for additional imaging and somebody needing to make a determination on if that's medically necessary or dentally appropriate.
Tom?
I think just to that you're right, that what I was kind of throwing out there and what Gary said was to that it can, I don't know how you just phrased it, fit in the same criteria as a pano. So, once every 5 years, except as needed for specific cases, and then you could determine that. But this, just like cost isn't the underlying issue here, the convenience of the existing provider network can also be dictating what we're saying is appropriate and not appropriate. So in an office that is treating our members like mine, and I have a cone beam, I shouldn't have to do weird workarounds or not get my service covered because I am providing a superior diagnostic service. And frankly, more offices would have them if they were covered, and they would be doing, right now, the limitation in coverage is keeping the offices from, I know offices, PCDs who have gotten digital panos within the last few years who would have got cone beams if they were going to be covered, but cone beams aren't covered. So I'm gonna just bring that up, and then I also want to just reinforce the idea. I like what you said, which is that we just put it in the same criteria as a pano, which is that it's covered as a diagnostic service once every 5 years with no limitation, and then more if needed and justified by whatever criteria like surgical planning.
Okay, thank you. So I'm hearing that I don't think there's any proposal on the table to eliminate coverage of pano. I've heard I think there was a few people that were concerned because we know the providers are different.
I'm the one who said that, and I was not meaning to propose that.
Yeah.
I said something to that effect, but I was not meaning to propose that.
So it sounds like there's some appetite for covering screening once every 5 years with pano or CBCT, and that would be something we would need to work internally to see if that's feasible and making a rule. And then an additional one would be covered with kind of this guideline note. I also heard there's some people aren't quite comfortable unless they can see it on paper. So what I'm thinking is we as staff will take this back, discuss it as a group, see what needs to be done in rule, what can be done with guideline notes, etc., and then we can bring it back to the next OHAP. Or would that be? I saw Stacy nodding. Is that okay?
I just want to validate if I heard something. I think I heard a couple of people suggest that we might need to add something to this guideline note, like, and 2D imaging is insufficient for surgical planning, or perhaps break that down a little more. Did I hear that correctly? Give me a thumbs up if I did, or a thumbs down if I didn't.
I think that's a great suggestion, Jason, actually. There's 2D imaging, and to move forward with providing appropriate patient care, safe patient care, so you're not damaging other structures, than 3D. The complex third molar extractions, we're doing 3D to prevent nerve injury. We have an alternative procedure called a coronectomy. It sounds crazy, but we take out just part of the tooth. And we have to have the 3D imaging to show that the root structure is in contact with the nerve. And then with supernumerary teeth, I talked about how the teeth can be, up against roots of other teeth. We really do need to have 3D imaging so that we can not harm a patient by damaging other teeth.
And those criteria would likely be different for each one of these 10.
Yeah. And probably would be a higher level of care. So this would be specialists probably that would be looking at this and making an evaluation and saying, to move forward with treatment, I really do need this cone beam.
I see Karen and then Ahmed.
I just have a quick question about the guideline note. I see that it does say retreatment of root canals, but I think the OHP plan only covers anterior root canal. So does that need to be added there, that we would cover it? I don't know. I'm just calling it out there that not all retreatment of root canals are covered by OHP.
No, isn't there some kind of also like kink around pregnant women getting more teeth covered eligible for root canals too?
Yeah, there could be, I don't remember the rule exactly, but I don't know if we want to say like it's covered when the retreatment of the root canal is covered or something.
Like in conjunction with a covered root canal treatment or something.
Right.
Yeah.
Could you tell me, so how would you?
So
I'm making some notes, Liz.
retreatment of root canals when done in conjunction with a covered root canal
Right. Yep.
retreatment.
Ahmed?
I would like Tom to go first, and then I'll go afterwards.
I was just gonna say that maybe since you've once we've accepted that it's okay for surgical planning, just get rid of the exceptions. Just get examples. Get rid of the examples. That if it's CBCT is dental appropriate for surgical planning, and basically it's covered if the surgery is covered. And so then for one example is retreat of root canals. If it also depends on like what criteria we're using for surgery, right? So I'm a old school dentist. I have a doctorate of dental surgery. So when I'm cutting a tooth to do a filling, that's dental surgery. I'm cutting, anytime you're cutting something, it's surgery. So oral surgery and dental surgery. So a root canal is surgical. A retreatment is also surgical. An apicoectomy is surgical, and some people would call the first two non-surgical and the third one surgical. And so I'm seeing some conflation of terms here of procedures and whether or not they're surgical. And since we've already decided that it's appropriate in some surgical planning, I would propose possibly just getting rid of the examples of the limitations. That if somebody's doing surgery, that it would just be covered if the procedure is covered.
Okay, Ahmed?
What if it's surgical planning in relation to like implant surgery that they're gonna pay for out of pocket? Sorry, just to I don't know. I'm not,
because the implant surgery isn't covered, I would say that then the CBCT would not be covered. So it's only going to be covered with covered surgical services under the organ health plan. I think that's what I heard Tom say.
So it's covered when
Makes
dentally
sense to me. It just kind
appropriate
of
for
simplifies
surgical
it. Like, if
planning of a
surgery's
covered. So surgery, CBT is covered for surgical planning of a covered surgical procedure under OHP, or we would obviously need to wordsmith something.
But yeah, I think that's where he was going with it.
Do other folks feel that we should do that, or do you want to continue to have specific called out situations where the best evidence we found is, or you?
I think what Stacy had just said was that she used the example of she would be okay with a 2D x-ray, and sometimes she might need a 3D image. And so it's up to the professional judgment. So this idea, which also I was a little confused with what Jason said, I wouldn't want to put in rule that 2D is not sufficient for surgery planning. That's going to be up to the professional judgment of the person doing the procedure.
Gary?
Well, my feeling would be to continue to have the limitations in the guideline note when it would be covered. And if we need to add more based upon evidence, I think we could do that. The apicoectomy is an example where, again, it might be appropriate for endodontic surgery, but I prefer to have the limitations when we are trying to make coverage decisions. It's very helpful to have those kind of guidelines. And we had talked about it before. I think Dr. Geisler mentioned it. We might want to add is dentally permit for surgical planning of a covered surgical procedure. I would just say a covered procedure, but I think we really need to add medically necessary to Dr. Geisler's point somewhere in there, because again, it would not be medically necessary for all third molar extractions. It would not necessarily be medically necessary for all retreatments. So, there should be some sort of indication that would further limit CBCT when a two-dimensional radiograph seems to be appropriate.
So we could say something like it's covered for surgical planning of a covered surgical procedure when 2D imaging is not sufficient. But you're also recommending continuing to have the list of covered procedures. That's what I'm hearing.
Correct. From a plan perspective of trying to make coverage decisions, which are invariably picked apart by administrative law judges and the patient themselves on appeals. So to have some sort of guardrails is helpful to us. And I think it's based upon evidence too. And again, if there are more evidence-based indications, we could add those, but I prefer the list.
Thanks. Jessica?
I'm curious if it would be helpful to have in the terms and definitions section of the Division 123 dental lawyer to have definitions spelled out for surgical planning and maybe some of these other terms that there's different interpretations of. This one for that happen.
Are you asking the group what that would be helpful to define in rule?
Yeah, well, I'm just wondering if there's some of these terms, for example, surgical planning. I heard, like Dr. Holt was saying that, perhaps different providers have a different idea or conception of what that consists of. So I thought if that could provide clarity, that's something that we could do in OER,
Okay, thank you.
All right.
Ahmed,
Can I? Yeah.
yeah, I was going to circle back to you, Ahmed.
Thank you. Thank you for that. I was going actually to go back and ask Dr. Holt for a little bit more dive on taking any field of view that has the maxillary and most likely will have the cranial base view of it. Do you really send these out for a read, or you do read them yourself?
So I can do an image volume that gets the maxilla and doesn't get the cranial base. I do also have a larger prediction that I do that gets the cranial base, and I read those myself.
Thank you. Yeah, that was just a clarification because depends on what machine you have and what settings do you have. You probably will expose some of the cranial base, and there are, I think everybody who buys CBCT is already aware of some of these cases and reports and medical legal issues of missing the diagnosis in the cranial base, and if dentists are really able to find these out and diagnose them or not. So just from a medical liability standpoint.
Well, I mean, dentists are essentially now involved in the care of patients for hypertension, cardiovascular disease, diabetes. Again, that's a very dentist perspective, this question that came up about what, or do we have to diagnose everything we see when we take panos and they're just terrible projections that don't show us anything that we don't need to see. We just need to level up our ability to diagnose. And so, I mean, that's the next bridge to get to that we've never gotten to because of the big gatekeeping bridge up front, which is why none of the providers actually have it.
Thank you for the clarification.
Okay, so I have heard a lot of wonderful input on this. I think the next step will be HERC staff will meet up with our dental colleagues at OHA and kind of discuss this and then bring it back. Does that sound reasonable to you all?
Dr. Farag, sometimes I do send them out also. I should throw that in there. Occasionally, I do send them out.
Thank you.
Jessica,
Yeah.
did you have something else?
Okay.
No, sorry.
Okay. Well, thank you all for a very lively discussion on that. We'll keep you updated. Like I said, the next couple of meetings where where HERC may discuss this is October 9th and November 13th. Does anyone have any other business that they wanted to discuss? Gary?
Yeah, Ariel. I'm the representative on the benefit update project, and it was addressed early on by Dr. Chaudhry, and I had asked Jason about it during the benefit update project work group meeting, and that is additional guideline notes for medical necessity to help us determine medical necessity with some of the benefits as we go forward, particularly for the EPSDT population. And the question I posed at the time is, is that something that OHAP can assist on? Because I think there's going to be a need for that as we go down the road. Not to say we're going to address it in the limited time we have left, but I just want to put it out there as a future agenda item.
I think what would be helpful to us is to have like examples of the specific clinical scenarios where you'd want to see a guideline.
And I think those exist. Some of those in the commercial dental industry already, where, for example, crowns are covered based upon certain conditions. And I think we could adopt those same sorts of things for the EPSDT population in reviewing for medical necessity. The example again would be crowns aren't covered for any of the population except for anterior teeth, where it's covered for kids and for pregnant patients. But in our requirement to review for medical necessity, there are occasions where it is appropriate, following, for example, a root canal on a molar tooth. And certainly in our practice or our plan, we have approved those and have kind of used the commercial guidelines to make those determinations. But having those in a guideline note or having them in rule would be helpful, I think, in making coverage decisions. So yeah, I think we can provide some of those conditions.
Yeah, if you want to send those to staff, the HERC.info, we'll be happy to look at whatever things you feel like might be beneficial.
Yeah, maybe we should start with a couple of examples and work through them, and then if it proves fruitful, and we could go with some more. But I think I heard two things, Gary, and I want to make sure I understand. One is for kids with EPSDT, there may be things that are covered in current rule that may not be medically necessary, and it would be helpful to have some guidelines to buttress that. And then I heard another thing, which was there are things that aren't covered in rule, but for which you've made exceptions, and perhaps we could codify some of those scenarios and include those in the benefit for adults and people who aren't pregnant. Am I hearing both of those things?
Correct. You said it much better than I did. So that's essentially what I was getting at.
Okay, thank you.
Jessica?
Hey, if we have time, I just want to give a quick announcement, and that's that we're holding the RAC with the Division 122 dental denturist rules. And that RAC will be on Monday, September 29th from 10 until noon. And so I can send out the announcement to this group, or for this to be shared with this group. That also people who are interested can email me. You can have one person per organization representing the organization, but I'll put my name in the chat.
Jessica.
Okay.
All right, and then Manu wanted to talk about pairing. Do we have time for that, Ariel?
We have 7 minutes. Manu?
So Jason, would you mind giving context for the group around the topics discussed around the idea of pairing? Or maybe Dr. Frog would be better just to level set and provide adequate background for the group.
I'm not sure I understand what the issue is. Our dental lines have diagnosis codes, but we know dentists don't use those most of the time, but oral surgeons do. So under the benefit update project, we would have lists of dental procedures in code groups in our we would have that same situation in the coding groups for the benefit update project. It's just we would no longer have an unfunded region. Things that are now below the line would be in that excluded file or in the not medically necessary file, as we discussed this spring and earlier today in a couple of instances. So, and we need to get some talking points and clarity around when is it not medically necessary and appealable and should be covered if it is medically necessary, and when is it just outside the benefit package, even if it is medically necessary. It sounds like that's a thorny question. I'm not sure how it relates to pairing. So I don't know if Gary or Dr. Farag can clarify another issue related to that.
I think the concern is that there is no pairing, from what has been shared through the benefit update project, because there is no pairing for dental, because we don't use diagnostic codes. Then, we don't necessarily have the same basis for determining or making coverage decisions as we move into the future, when we won't have a prioritized list. And that's the reason, that I'm suggesting that it's going to be helpful to have additional guideline notes in the absence of diagnostic codes to help us make those decisions after the prioritized list is eliminated.
Okay, yeah, so that's the rationale for the discussion earlier, that we may need, because we can't just throw a diagnosis code on and it doesn't make the situation clear, we need to write it out in plain English and say, this procedure is only covered when the patient meets X, Y, Z criteria.
Yeah, that's what I'm recommending in the absence of diagnostic codes.
Okay, then I would ask all of you on the call who are involved with this work, especially the dental plans, just to email us examples of where that would be helpful, and we will discuss those and take them into consideration.
Gary, why don't we just use diagnosis codes? Why don't we just make that change?
I think that's a bigger, broader.
Above my pay grade, but I wouldn't be opposed to that. I think it would make things a lot easier. But I think that's the code maintenance committee and all, for whatever reasons. Actually, it's I think the American Dental Association has basically been opposed to it. But that's a political thing, I think, as well as more so than a realistic or a legitimate argument against it. I think we should be using them. Just my opinion.
All right, I see Ahmed and Asma's hands raised, and just as a reminder, we only have a couple more minutes left. So, Ahmed?
Yeah, I think Asma was first, but I'll just chime in briefly on the diagnosis code. Yes, I agree with Dr. Holt. Why not? And definitely we can probably think about this in the future. But currently, right now, just for everybody awareness, and you can research that, there are few state Medicaid programs that require dentists to submit the ICD-10 diagnosis codes in addition to their dental codes. Oregon has not done yet, but there is a huge move from a lot of state Medicaid directors to look into this and actually champion it over the next couple of years. So just so that you all should know this, it has been done in other places, and a lot of the software, the dental software vendors are already applying ICD-10 in their softwares as we speak. So just thought I would share that with the group.
Great, thank you. Ozma?
Hi. My comment was similar to what Dr. Frog just said in terms of like we use Epic electronic health record system. ICD-10 codes are already built in. Again, I don't understand the nuances of what that means. I'm simply sharing that ICD-10 codes are part of it. I would love clarity on what that means, because like the group is suggesting it's not currently part of our yes, we use diagnosis codes, but we're choosing diagnosis codes based on, hey, clinically, this is what I think. But it would be really helpful to know, okay, well, these are the, like, if we're requiring that level of pairing, hey, these are the ICD-10 codes that you should attach, and we can build systems around that. So whenever that discussion comes up, I would love to have clarity on, hey, here's your code set, because there's a million codes that we can use.
You tell me
I'm
about
being
it.
facetious, but
No, there are hundreds of thousands of codes, but yeah, I don't know how many would apply in the mouth, but yeah.
Thank you.
Okay,
That
great.
was all I was going to say.
No, thank you. So we are at time, and I want to respect all of your time, and I want to thank you all again as a very non-dental dental provider. I really appreciate all of you and your expertise, and thank you for taking the time to join us and share your expertise. And yeah, we will at this point, especially if we do need to start thinking about guideline notes, we probably would schedule another OHAP at some point in the winter, and then we can talk about cone beam CT a little bit more at that meeting, and then whatever guidelines, if we decide that's where we want to go, we'll keep you updated if we do decide to have, so we always have OHAP around this time of the year because of the CDT codes. If we decide to have an additional meeting the fall of the winter, we will let you all know, obviously, and we'll send you one of our little survey things to find out dates that would work for you. All right. Thank you all again, and hope you guys all have a wonderful day.
Thank you.
Bye.
Thank you. You too.
Thanks all.
Appreciate it.